So I think we have got a very good session. Conceptually, it is a great concept. We have been discussing this for quite some time. And now, can you do that? See if... So basically what we are discussing here is quite pertinent to contemporary research actually. And research has become part of practice. So that's another dimension. And that opens up a lot of vista. But that is the most important part. So I will introduce the subject and then Dr. Sandeep Saxena from KGMC is a professor. He will be talking about AIOS disease and will be correcting the spelling as discussed by Dr. Sandeep. Then diabetic macular edema will be discussed by none else than Manish Tandon, Professor Manish Tandon. Then we have coined a term retinal inflammatory neovascular conditions. And we have presented last time also, and this time also we are going to present the same. Who knows, in the coming time that becomes an acceptable term. And Dr. Avijat will be presenting on his experience on OCTA basically. The topic was FFA, OCT, OCTA, so he said, no, I will be discussing only OCTA. Then Professor Ajay Dudani is on the way, and if he comes and joins in, then he will be talking about lasers, and diabetic macular edema will be discussed by Dr. Ajay Arora. So with this, I think, let's go and start. I will start my presentation, and then the subsequent presentations will come. So as I was discussing, angiogenesis we have been taking this for last almost 5 years now. And the first thing we did in COVID times was a web meeting on inflammation and neovascularization. JB was involved in that, and that had a very big audience at that time. And yesterday also I was talking about him, then he said, if he gets time, he will come. So the topic is actually very pertinent. The only thing is, only few people are aware about it. Professor Sandeep has done a lot of work on this. The question is, why this correlation between inflammation and neovascularization? And as the photograph shows, that these two diseases, they coexist. So the question is, are they a continuum of the same process? So everybody is discussing about, when we talk of angiogenesis, we talk about VEGF release, and the common insight is hypoxia. But before that, a lot of things happen. So we have to look into things beyond VEGF. Already one more salt is there in the market, which is talking about other receptors like ANG2 and ANG1. So what I understood was there are two types of reactions. One are innate to the system, and other is autoimmunity, which is expression of through tissue response through the cells which come to the point. And if they are optically visible, we talk about uveitis. And now when we talk of inflammation, actually we are not talking of uveitis, but we are talking about intracellular things which are happening and which is responsible for all the disease manifestation. Retina is an immune competent tissue, and there are so many cells, as mentioned on the left side, which are able to produce tissue response. So that is the difference we have in the retina. Now, I was discussing in the last meeting of UP State Ophthalmic Society about inflammation, and then somebody said, why don't you go and read Robbins? So then I went and read Robbins. And this line is very catchy. Process of inflammation is fundamental to virtually all clinical medicine. So there is a cellular component which comprises of leukostasis, margination, chemotaxis, phagocytosis, and there are chemical mediators which will process the inflammation. So when you see inflammation, it will either resolve, or it will heal, or it will cause fibrosis, or it becomes chronic, and then angiogenesis comes. So this is the various courses taken by the inflammation procedure. And these are the chemical mediators which are released when inflammation is there. So there is a self-derived, some chemicals are cell-derived, and others are systematically derived. These photographs are very catchy and very interesting, so I just took it from the book. And that is the chemical cascade which is involved in inflammation. We know about arachidonic acid pathway, and these are the mediators which are working in the inflammatory environment. So let's take the example of diabetic retinopathy. How metabolic disturbance will evolve into oxidative stress, release of pro-inflammatory mediators, will cause ischemic immune response, that will cause disturbed vascular health, and then edema, and then angiogenesis. So if we talk about angiogenesis, how the cells, they grow is, the pericytes will move, endothelium will grow, and then pericytes will come down. So that means some growth is required, and that is why these growth factors are coming into picture, and there are 4, A, B, C, D, E. And yesterday somebody was mentioning that VEGF-A is probably the most important one. The other factors are FGF, which are 20 in number, and angiopoietin, which are 1 and 2, which are basically dealing with pericytes. So there is hypoglycemia, which leads to activation of this inflammatory cascade, which creates pro-inflammatory response, ischemia, and then there's VEGF release. It creates a low-grade inflammation, and then the blood-retinal barriers are affected, endothelial dysfunction comes, and the disease develops. So this is all discussed so many times: hypoxia, VEGF release, angiogenesis. But before that, there are so many things which are in the process of targeting when we are talking about the clinical studies, and we are likely to hear more about it. And that's the correlation of inflammation and neovascularization. That is why we have used the term retinal inflammatory neovascular conditions, because whether we are dealing with CR, branch vein occlusion, whether we are talking about diabetic retinopathy or other diseases, the etiology remains same. And that is why a composite term has been used. Thank you very much. With this, this was just a prelude to the entire session. And now we have Professor Sandeep Saxena. He is from King George Medical College, Lucknow. He has been a great academician. He has many presentations, many books. It will be difficult to actually mention. And in this meeting also, he has a lot of commitment. And he has been working on this. When I said I want to do this He said, okay, I have AIOS disease as the prototype. So we were discussing diabetic retinopathy as a prototype. He will be talking about AIOS disease as a prototype. Let's see. He prepared his presentation elsewhere. I prepared my presentation elsewhere. Let's see. Is there a confluence or we just go heavy? It's Professor Sandeep Saxena.
संदीप सक्सेना वाला लोड कराया हुआ था कल लोड करके चेक भी कराया था उन्होंने कहा था कि वहाँ तक जा रहा है हमारा प्रेजेंटेशन सब दिखा दिया था स्लाइड हम नहीं लाए हम नोट करा के वहाँ पे डबल चेक करके हमारा कोडिंग तक जा रहा है
अगर आपके पास नहीं आया है तो आप वहाँ से बात करिए इतना कहने से काम नहीं चलेगा so you can't shrug off your responsibility yeah contact your preview room and see what has happened to the presentations uploaded in the Kesar Hall so yeah till Professor Sandeep is doing his uploads may I call Dr. Manish Tandon he is a prolific retina surgeon from Prayag. He has been a consultant in Arvind Eye Hospital. And ROP is actually his main area of interest. He will be talking about diabetic macular edema, a clinico-pathological walkthrough. इनका प्रोफेसर मनीष का प्रेजेंटेशन है अपलोडेड लैपटॉप है ठीक है दिस इज व्हाट वी लर्न
Good morning, respected members. At the outset, thank you to Malay sir for this opportunity. And this is the second time we are doing this inflammation and neovascularization instruction course. And it's an honor to be here. So, it is not coming on the, okay. So, the pathogenesis of diabetic macular edema is very complex and it's multifactorial. We all know that the primary culprit is a sustained hyperglycemia, which causes release of the death of the cells and release of a lot of mediators. Primarily, they are the inflammatory mediators which lead to some form of edema. There is oxidative stress and these kind of things happen. The inflammation leads to hyperpermeability, the death of the pericytes, the capillary walls get damaged, leads to the death of the capillaries, which leads to hyperperfusion, and then the neoangiogenesis happens. What I will be covering will be the cellular and molecular mechanisms, hyperglycemic animal models, non-diabetic mouse models, and then I will summarize the current knowledge. So, it's the diabetic retinopathy is the most common microvascular complication with the higher incidence of people, the type 1 diabetes compared with the type 2 diabetes mellitus. The increased prevalence of diabetes in developed and developing nations, it is the leading cause of vision loss globally in the working middle-aged people. So, estimate prevalence of any form of DR is about 34.6% across 93 million worldwide. We all know that the blindness happening due to the retinal pathologies, the 8.3% people of the world population is affected by diabetes, which is about, extrapolating the data, is 20.6 million. And the majority of them are the DME patients. Risk factors are sustained hyperglycemia, hypertension, dyslipidemia, pregnancy has been inculcated. And certain diabetic populations do not develop diabetic retinopathy in spite of these because of the genetic susceptibility. In the past decade, the pharmacological therapies using anti-VEGF drugs and corticosteroids have dramatically changed the clinical management, but their limited efficacy and potential adverse effect, we need to understand more about the pathophysiology, and that is what Malay sir was talking some time back. So currently the diabetic macular edema, I'll come back to the topic. It's diagnosed by slit lamp or by OCT. Macular edema is the retinal thickening, accumulation of fluid within the neural tissues. Anti-VEGF has become the standard of care for diabetic macular edema. The clinical types of diabetic macular edema are the spongiform edema, cystoid macular edema, serous detachment, the mixed variety, which is the commonest, foveal traction, tout posterior hyaloid, and confounding agents like the OCT biomarkers. Now, this is typically spongiform edema. Edema is limited to Henle's layer. Earliest form of edema it happens due to the damage to the microvasculature, and it responds very well to lasers. So here we don't have to inject anything. Cystoid macular edema is mainly VEGF driven. Inflammatory mediators do have a role. The treatment of this is either anti-VEGF or the steroids. This is what I'm not showing the picture how it responds, because all of us have seen those pictures, how it responds. We have patients. The serous retinal detachment is very interesting. There is an underlying cause. When we see a serous detachment, there's an underlying cause like hypertension or of renal failure. These patients have to be investigated well, if especially it is bilateral. It is self-responding when the systemic disease is taken care of, and it responds very well to steroids. So serous retinal detachment, instead of anti-VEGF, steroids should be the first line of option. Vitreomacular traction, this is how it looks. May or may not have very significant effect of vision depending on which area is involved. Primary symptom is metamorphopsia rather than vision loss. May resolve on its own. If you do laser, it resolves sometimes it resolves spontaneously, and sometimes surgery is mandated if it is causing tractional detachment. This is a tout posterior hyaloid causing tractional detachment. The pre-op and the post-op, these patients definitely require, if this kind of an OCT you see, you have to treat these patients. If the vision is not much affected, even tout posterior hyaloid can be observed. Sometimes, picture like this on your left, we don't have an option. This was a patient who came to me from Lucknow. He's a very high-ranking government official, poorly controlled diabetic, renal failure with foot ulcer. There was nothing that we can do. He could not sit for a long time. He was overweight. So we didn't have an option. So we gave him some anti-VEGF because he was bleeding at that time. And to my surprise, I saw first time to your right side, after 3 anti-VEGF, the blood had actually reduced and he started gaining vision. And now he is having a very good vision of 624. We just did the laser after that and the blood resolved. OCT biomarkers are the confounding agents, and these things, this kind of cystoid change which looks like a cyst usually do not respond, so please do not treat these patients. We can see a pearl necklace sign all around the cyst which is seen, and if treated post 3 injection, the pearl necklace sign will go, but not the cystoid change, because this is not a true edema. So the take-home messages is diabetic macular edema is the aftermath of poor systemic control. Take care of the patient, not the eye alone. Be careful with the usage of anti-VEGF. Choroidal perfusion should be monitored. Focal and grid lasers are very good options, especially for spongiform edema and extrafoveal leakage. Steroids work very well because of the multiple systemic diseases and history of thromboembolic episodes if we cannot give anti-VEGF. Many drugs are in pipeline, but neuroprotective agents are also having their role. Thank you so much.
Yeah, very nicely presented, Dr. Manish. You said something about laser, although this is a topic which will be taken care separately, but where you will first go as anti-VEGF and where you will go first laser?
Sir,
Or what combination are you looking at when you're talking about laser?
proliferative diabetic retinopathy, the first choice is always the lasers. And once laser is done, then we can always inject later with steroids or with anti-VEGF, whatever the clinician's call is. For extrafoveal leaks and for the spongiform type of edema of the diabetic retinopathy, the macular edema, lasers I still prefer, and I do a lot of grid lasers.
Yeah.
It reduces the number of the VEGF load.
So,
Number of injections.
do we have a floating mic? Although it's not required, but anyway.
So especially for focal macular edema, as you rightly said, in the center of the exhibits, it works beautifully, reducing number of injections. But even in spongy edema, if you laser within the arcades, don't go very close to the fovea, because after 30 years of practice, I've realized that my old laser burns have creeped on and affected the fovea also. So now I'm very scared, that I try to stay away, very far away, just within the arcade, 2 rows I give, avoiding the papulomacular bundle
That's
for
a good
spongy
call.
edema. Yeah.
That's a good call.
First you are, Mike.
If you look at the ETDRS reports, the ETDRS recurrence report came up and they said that initially you treat up to 500 microns from the center of the foveal avascular zone and don't go closer. But the recurrence report said that you can come up to 300 microns. But that was before the drcr.net study came up, which said that when you have, so that is very important for people to understand what is subfoveal edema or what is the central subfield thickness edema. So that is central 1 millimeter. A central 1 millimeter is 500 microns on either side. So the basic fundamental is, I personally feel that you should not go more than 750 microns from the center, because as Ajay said, it can extend to the center. If I'm 750 microns, maybe it will extend another 50 to 100 microns. So I'll never be closer to 500 microns from the center. So that is for doing the focal laser. Beyond that, you can anyway do it. But I use a lot of steroids, and I use a lot of steroids in the suprachoroidal injections, which makes, and have had dramatic results. We have now had a large series where we have injected in multiple conditions, and it's really giving extremely good results. Imagine a silicone-filled eye with a macular edema. You can't inject in the silicone oil. You inject suprachoroidal and it works beautifully well. There's no way of getting a macular edema off in a silicone-filled eye, because either you give topical, it doesn't reach. You give intravitreal, it doesn't reach. You give suprachoroidal, it causes macular edema to go down.
Yeah. Sandeep sir, your take on this?
One other point I would say,
You can give one more mic if you have.
Yeah, I think nothing much to add to this, and I feel laser is the best anti-VEGF till date, so we have to keep on using it in our scenario, although in the West people are sort of giving it off, but I still feel that laser has an important role, especially in DME cases where,
And what
where things
about,
don't stop.
sorry, what about the threshold or sub-threshold laser, what we are discussing? As I will show.
Yeah.
Yeah. Okay, no problem. So it's interesting.
Thank you, sir.
Yeah, thank you. And we'll talk, we'll listen to now Professor Sandeep Saxena, and he will be talking about EELS disease.
So as Dr. Malay said, that EELS is a prototype of vasculitis and neovascular confluence, and I'll be dealing with this subject. As we all know that retinal vasculitis has a number of causes, and some of them are mentioned over here, but still I will be focusing on EELS disease, which is a disease of our part of the world. So it's prevalent in India, Southeast Asia, some part of Eastern Europe, and somehow it has a male predominance. The disease is characterized by a triad of retinal periphlebitis, capillary non-perfusion, and neovascularization. So I'd like to just present for the audience the clinical spectrum of the disease, which you can see over here. That you can see superficial retinal hemorrhages and associated periphlebitis. Here, the things are still more florid, and you can see a venous occlusion which is associated with periphlebitis. Here is another example as the things progress and the disease goes into the proliferative stage. You can see multiple NVEs and associated macular edema also in this case. And finally, some of the cases present as central Eales disease, which is basically papillophlebitis, which is associated with vasculitis. Now, the lesions show up very well on fluorescein angiography, and here you have a confluence of inflammation and vascularization. You have an NVD, a neovascularization of the disc, an NVE, and associated leakage of the dye from retinal periphlebitis. So this is a very good example, and here you can see that besides vasculitis and neovascularization, you have large areas of capillary non-perfusion. So due to vasculitis and decreased vascularization or hypoxia, as mentioned before, the capillaries have been knocked down in the retina. So basically, this is a disease of the young males, and things somehow go unnoticed, and the hallmark still remains that the 50 to 60% of these cases present with a vitreous hemorrhage, which subsequently go into the recurrent phase because either the person is not knowing or he's not caring. So these cases come like that. So now I'll be focusing on the etiopathogenesis of this condition. And we know that a hypersensitivity to the extraneous agent, which might be tuberculosis, causes the release of retinal S antigen from the retina, and this leads to an autoimmune inflammatory response. So we had discovered autoimmunity in Eales disease way back in 1999, and this subsequently leads to retinal periphlebitis. There is an enhanced oxidative stress which is associated with Eales, and also there is an associated cytokine profile change, and all these things culminate subsequently into a photoreceptor damage, retinal vascularization, which results from an increase in the VEGF expression. Now, what I have been able to do over the past 20 or 25 years is that we have been able to translate our work into clinical practice. So the laboratory science of ours has led to the development of novel therapeutic strategies in Eales disease. So when we discovered an increase in the T-cell response, this led to the start of oral methotrexate pulse therapy, and that goes well with this. An increase in the oxidative stress led to the start of antioxidant supplementation, which I do regularly for these cases. And the IL-1 beta and TNF alpha were discovered as novel targets maybe 15 years back. And so this immunosuppressive therapy in the form of anti-TNF alpha therapy has also been proposed. But due to the high cost and the lower socioeconomic strata, the patient somehow is not able to undergo these high-ended treatment strategies. Now, 20 years back, we developed an Eales disease classification system which takes into consideration both the inflammation and the neovascularization concept. So this is a simple easy to recall, and this takes into consideration the clinical and the fluorescein angiography variables, and based on this, we have the disease severity and management strategies. So just to summarize, we have Eales disease per se and the central Eales disease. Now the Eales disease can be divided into 4 stages. Stage 1 is the stage of inflammation, where the retinal periphlebitis is basically involving the small caliber vessels. Stage 1B is a periphlebitis of the larger caliber vessels. Stage 2 is the stage of retinal ischemia and neovascularization, where 2A is retinal capillary non-perfusion, and 2B is the stage of neovascularization in the form of NVE or NVD. And as the disease progresses, the next is the stage of proliferation and hemorrhage, where we have fibrovascular proliferation, and subsequently as the vitreous contracts and this fibrovascular tissue gives way, this leads to vitreous hemorrhage. And finally, as the disease complicates, we have the stage of complications, where this is a tractional or agmatogenous component of the detachment. And as a last stage, the patient may present with rubiosis, neovascular glaucoma, cataract, and optic atrophy. Now, based on these stages, likewise, we have developed and proposed the management strategies. Stage 1, the stage of inflammation, has medical therapy. Stage 2, the stage of ischemia and neovascularization, has either observation or laser. Stage 3, the stage of proliferation and hemorrhage, has either laser or pars plana vitrectomy. And stage 4 of complication requires more sophisticated strategies. So our classification system has had a favorable visual outcome if the patient is treated well, based on this grading and the management strategy system. And now, over the past few years, our classification system has been included in the American Academy of Ophthalmology as the standardized classification system for Eales. So now that is the global standard of care for Eales disease. And all the stages we had proposed 20 years back are now with the American Academy. Now, fluorescein angiography plays a very important role and highlights the things which somehow we are not seeing. And as you can see, that the things are very clearly visible. And we also tried to see the relationship between the retinal ischemia and neovascularization. So 20 disc areas will lead to an NVE, and 60 disc areas of CNP will lead to NVD. We also focused on the topographic distribution of retinal neovascularization and found that the superior temporal quadrant was found to have the maximum number of NVEs. Now, macular involvement previously was unknown in Eales, and about 25 years back, I highlighted that macular involvement is not common in Eales, and we presented a series and published a series of 175 patients. So here are some of the examples of macular involvement, and here also we can see the pull on the macula due to the tractional component and an increase in the foveal avascular zone, which might be associated with this condition. Now for Eales disease, we have the medical therapy in form of corticosteroids and immunosuppressives. We developed oral methotrexate pulse therapy, which can be given for a period of 3 months to start with. And the basic concept is that the pulse differs from a chronic moderate therapy and has the ability to reset the aberrant immune response. And also the pulse may just abolish the source of antigens, and the disease to this, the response to this therapy usually starts in about 4 weeks' time. The only precaution is that tuberculosis per se has to be ruled out. Dr. Biswas has already showed in a great work of his that he examined few hundred patients of tuberculosis and did not find vasculitis in even a single case. So his observation has been that TB vasculitis may be a different thing, but here the things are different. So in this slide, you can see the response of oral methotrexate pulse therapy. You can see at 12 weeks how the things have improved, and on the right, at 6 weeks as the things have started to improve. And we can also use a combination of corticosteroids and a simultaneous methotrexate. The steroids are stopped at about 4 weeks' time when methotrexate starts to pick up, and that goes well. Antioxidant supplementation should be considered because that relieves the oxidative stress and then the cascade of vasculogenesis also. A B scan helps us in defining vitreoschisis in some cases where we are planning to do surgery. Here is just an example. Photocoagulation, as we discussed, remains a mainstay of treatment still for the retinal diseases, and things improve after laser therapy, and we can see a residual stock at the level of the disc. Vitreoretinal surgery should be practiced now because the instrumentation has improved dramatically, and previously it was thought that one should wait for 3 to 6 months, but now I feel that in about 4 weeks' time of hemorrhage, the PVD has happened, and if the things are not resolving with anti-VEGFs, etc., then we should go in for surgery for a quicker response. Intravitreal anti-VEGF stays with the disease, and here is just one example to show how things improve after intravitreal therapy. Thank you very much.
Professor Sandeep, thank you very much. It was
sorry I took a bit time, but
questions are very important part.
Yeah.
I just wanted, I was always thinking that why this condition only causes the periphlebitis and doesn't affect the arterioles, you know? Any hypothesis for that, sir?
No, I haven't developed a hypothesis for that, but then the veins are predominantly involved in this, and somehow the left eye also I have observed as already reported that somehow the disease starts from the left eye predominantly. So that not be the case all the time,
right,
but
sir.
in the majority of cases somehow.
Sir, and what is the role of AKT as per your experience, sir, in these patients? Like a patient with active eels, if there is some Montux is positive, then would you start AKT in these patients?
Yes, then only I can start because that hypersensitivity thing will go down.
Okay.
So that source which is hitting the retina all the time, that might be a tubercular factor. So that will be helped out. These patients are not frankly tubercular.
Okay.
But I think before the start of this immunosuppressive therapy, one has to be sure that the patient is not having any component of tuberculosis per se.
Fine. Thank you, sir.
Thank you.
Any comment from Dr. Sethi? Yeah.
So one question, sir. Very clearly you mentioned nicely. My question is, clinically, how do you, in your experience, differentiate a tuberculous vasculitis versus an Eales disease? What do you think is something that you will, lean toward the tuberculous vasculitis, irrespective of the other investigations?
Well, what I have seen is that these are the guys from the age of 15, 16 up to the age of 30 years or so. They are practically healthy. So, as per se, you are not thinking of tuberculosis at all. And all the features which we see first time in the eye, they just fall into the Eales disease group. And we have to do this tuberculosis workup definitely. But usually, I've seen that these patients do not turn up to be frank tubercular per se.
Like so,
and the other thing which is a bit thoda sa hatke se, that the diabetic membranes grow horizontally, whereas the Eales will go vertically up from the disc. So that is one, and I've not been able to know that how and why the things are there. But just by the look of the eye, you know that this is eels. Although you have to do all kind of investigations, but that is how things
Just one quick comment. Usually we think that's from the capillary to large venules. You said 1A involves large venules, then small
Yeah,
venules, then
small then
capillary.
large, yeah.
हाँ, उल्टा है इसमें, ऐसा कैसा है?
नहीं small पहले इसमें आता है.
The capillaries come in stage 1, stage 2, and veins come in stage 1. That is what you have mentioned.
नहीं, that is capillary non-perfusion areas isn't stage 2. Stage 1 is periphlebitis only.
Okay.
Sir,
Okay, yeah.
one question I had was, when do you consider doing laser in these patients? What is your
I think
criteria?
laser is just like you do for all the retinal diseases. With the help of medical therapy, the inflammation has to be knocked down first.
No, sir.
Once the inflammation has been knocked down and you find that there are areas of CNPs, and in the majority of cases, 50 to 60% will be having vitreous hemorrhage. So there you have to start with laser.
Sir,
So-
I did not
so like
put my
that.
question clearly. Sir, is there a role of the disc diameters of the capillary non-perfusion areas and
Sir-
doing lasers, or the presence of NVE, NVD is must before we consider laser? Because
good
these
question.
do not bleed as much as the diabetics.
Yes. So as I had shown, that was more for research कि आपका 20 disc area और जो है 40 disc areas.
Yes.
But once you have done fluorescein और आपको एक mentally लगा कि ये तो 40 area के आसपास जा रहा है, then you have to see that the patient can come on follow up or not, and then you have to decide. आपको नापना नहीं, नापना तो रिसर्च के पॉइंट ऑफ व्यू से एक आपको ग्रॉस आइडिया हो जाता है कि यहाँ पर NVE हो सकता है या NVD हो सकता है, and so on.
Yeah, he mentioned about that CNP
Thank you, sir.
20 diopter and 20 disc
Yes,
and
yes.
8.
And
That's a
40,
very good thing. I think.
This
We can
disease
use
is
in diabetic
male dominance.
retinopathy also.
No, in female incidence is less. Is there any hormonal factor?
Hormones
Why-
I haven't studied, but I feel that since the males are out of the house, exposed and all those things,
Yeah.
और अपने देश में हवा में ही ट्यूबरकुलर तो है ही. हम लोग को जो है ट्यूबरकुलोसिस नहीं है, लेकिन हवा में ट्यूबरकुलोसिस
TB
है.
है.
So उसी
हवाओं
की
में
हाइपर
TB है.
उसमें हवा उसकी जो है हाइपर सेंसिटिविटी उसमें आता है sort of.
So the next presentation is Dr. Avijat Chaturvedi. He will be talking about OCTA, a prolific speaker and a young ophthalmologist, young budding ophthalmologist.
We're still budding. In front of all of you, I'm still budding. So very good morning to everyone. Why I chose to speak just on Octa, because I feel just like suprachoroidal injections, Octa is something which is an underdog in the field of investigative retinal, diseases. So Octa is something which is very important, a diagnostic tool, a patient education tool, and how can you use it in various diseases which include neovascularization. I'll just show you that. So coming on to the commonest pathology which we encounter in OPDs is diabetic retinopathy. Now, what do you see in diabetic retinopathy? So the red arrows, they show some small white dots. These are nothing but microaneurysms. Now, why you need to know this? So the image on the left, the patient clinically showed no signs of diabetic retinopathy. And this patient was sent away that, no, you don't have diabetic retinopathy, come after 1 year. But as soon as you do an Octa, you can clearly see that these red arrows are showing CNP areas. These are capillary non-perfusion areas. And this is a microaneurysm, and this is a microaneurysm. So this patient is having mild NPDR. So maybe you'll start an anti-inflammatory drop, do a systemic workup, and maybe call him back in 6 months or something. So since this is a non-invasive tool, and you can see these are beautiful images of NVDs and NVEs, which can be recorded. Similarly, this is another image. It shows neovascularization elsewhere. So how do you identify that this vessel is having neovascular tissue or component or not? So when I zoom this image, you can see that the caliber of the vessels changes. So apart from the surrounding CNP or non-perfusion, you can see that this vessel, the neovascular tissue is broader. It has more fluorescence. So that is somewhat a identifying feature of neovascular tissue. So these both the photos, the purpose of putting them here was that when you do an FFA, you just study the superficial layer, what's happening there. But with OCTA, you can study the superficial layer, the deep layer, the outer layer, even till the choriocapillaries. If you just do an OCT scan, you can see that there's a B scan image here. You'll see whether there's edema or not. But how deep the pathology is going on and the depth of vascular disruption can be beautifully studied using this investigation. And this will help you in determining the prognosis and how your treatment course alters. So this is something which is happening normally also. There are flow voids in choriocapillary area in the OCTA, but in diabetics, these just coalesce and become a little larger. So this is my patient of vein occlusion, and OCT findings, we all are aware about that. Now, why do you need to do an OCTA here? So if you do an FFA or if you just see this B scan image, you can see an edema here. This is the superficial scan. And it shows that, yes, there is flow void. But this is actually not a flow void. This is just edema that is masking. Now, when you go to the outer scans or the deeper scans, you actually start to see the non-perfusion areas. See how the non-perfusion is increasing. And since it's going to the level of choriocapillary, this determines that this is an ischemic type of vein occlusion and not a non-ischemic type. You can also quantify this perfusion. And this is what I'll show in this slide. So these values show the vessel density and how the vascular perfusion is there in that area. And you can do that for all the levels. And why do you need to do that? So this patient was injected with aflibercept, and after 5 weeks, the edema has gone down in B scan. So this looks a pretty good image, okay? And this was before the injection. This is out after the injection. Now, the quantification about which I told, why do you need to do that quantification? That I'll show you. So on the left side is pre-injection, on the right side is post-injection. So you can see that values here, like this was 36, now this has become 44. So the perfusion is increasing. And similarly, grossly if you see, this was the entire area of non-perfusion and it is slowly regressing. The revascularization is coming back. And this is something which is helpful for yourself also, and you can educate the patient also. See, the injection is showing effect. It is getting revascularized. So this was a case published. This is a very rare thing, which is a triple cilio-retinal artery sparing CRAO. See the amount of non-perfusion. So the patient was sent for cardiology workup and a cardiology treatment. A stent was placed, and after that, see the beauty. It has vascularized. Though the vision doesn't improve much. Why? Because this entire area goes atrophic. Though revascularization and reperfusion happens. Similarly, this is a case of old STBRVO. Now, the patient has high blood pressure. I don't want to inject a dye. I don't want to do an FFA. So here comes the role of OCTA. You can observe neovascular tissue over this area. And then you can proceed with the injection. However, if you do an OCT B scan, it shows that there is no edema. So why would you like to go for an injection? No. In dry RMD per se, there's not much role of OCTA. It will just show you a masking effect because of presence of drusen's in the choriocapillaries. However, in wet RMD, so this is a beautiful image. In the deep and in the outer and the choriocapillaries, these white areas are nothing but geographic scars. I'll still do a injection in this patient. Why? So if you observe the superficial and deep layers, you can see something is happening here. Some new tissue is developing here, which is approaching the fovea very rapidly. So just for this sake, I would go for an injection in this patient. And again, you can show this. And after injection also, you can observe this thing. It is a beautiful modality to differentiate between type 1 and type 2 CNV. So like the image on the left is a type 1 CNV which occurs below RP level. So you can see at the level of superficial, there is no CNV net. This is the deep layer, this is the outer layer, and this is the choriocapillaries, where all in three you can observe a presence of CNV net. This is type 1 CNV. In type 2, you can see that there is some net, some CNP area, even in superficial, the deep, the outer. This is not flow void. This is again a masking effect because of presence of intraretinal fluid. There are variety of CNV net patterns like C fan, medusa head, tangled, prune tree. Why do you need to know all this? You need to know all this because with injections, the CNV net actually regresses. And you can document it with Octa. I'll show you one last case, which is again a published case. This was a girl, young girl with choroidal osteoma with CNV. So you can see this OCT-B scan shows a choroidal osteoma with IRF. And this is the Octa image showing CNV net. The girl was injected with injection Eylea, and after 6 weeks, there is some regression of IRF. Though the CNV net doesn't regress much, the injection was repeated at the stage. And at the stage of 12 weeks, you can clearly document some regression of this CNV net. So this is the beauty of Octa. You can actually study the depth of vascular disruption, the regression of CNVs, which are not to be documented by any other imaging modality. So the take-home message for me is that it is a non-invasive, rapid image modality. It shows multi-layered choroidal and retinal architecture, and it is helpful in detecting preclinical disease. And it is a very good patient education tool. It is important in monitoring the disease progression and observe the prognostic value of the condition. Thank you for your patient listening.
So one quick comment from Professor Dudani. Yeah, Manish, please.
It was a very good presentation, Abhijat.
Thank you, sir.
Just one thing, does the type of the CNV that you see, you showed so many medusa head and the other forms, the fern tree, does it have a prognostic significance?
Yes. So, there's one study, sir, in which out of these 5 to 6 appearances which are there, a couple of them claim that yes, there is some prognostic significance. If that becomes a a pruned tree or a branched pattern, then that has a better prognosis. A medusa head has a good prognosis. But however, if it becomes entangled, the entire area of CNP increases, and that tends to have a poorer prognosis. But still, a research study has to be done involving all the types.
So one question I had, Abhijat, is that which is the machine you're using, by the way?
So I'm using Hewitt's, and images from in this PPT are from OptoView also.
OptoView also.
Yeah.
So I wanted to know, supposing you have a CNVM which is documented on Octa.
Yeah.
There is no intraretinal or subretinal or fluid there. Will you treat that like how we call as a Octa CNVM which is not clinically evident?
Yeah. So the thing in that is, I also take in account the age of the patient, the prognosis, is there presence of a scar there or not. If there is no scarring, then yes, I will go for a treatment and document it. So after one injection, we can do another Octa image.
True.
And if it shows some regression, then yes, why not go for a treatment?
Yeah, but the patient is 6'6" when he doesn't have IRF. Or
If the patient is 6'6", I don't touch it.
Okay.
I don't touch it.
Yeah, that's a good thing. So I think you don't treat the Octa, I think.
Yeah.
Still, you have to treat a clinical OCT which is showing IRF, SRF or some fluid in one of the components.
So
am I right?
All my presentations, sir, I say that, yes, I am talking about this modality, but you need to treat the patient and not the investigator.
Great,
too.
great.
I just for the entire panel, I'm just throwing a question. If you have an Octa and the patients, if you have a CNVM which you can demonstrate on Octa, the OCT as such does not show fluid, obvious detectable fluid, but the patient is symptomatic. What do? Do you say, no, I will not treat? The reason I'm saying is just think about the resolution of an OCT. The lateral resolution of an OCT is 15 microns. The anteroposterior resolution, the lateral resolution on a OCT, whichever OCT, including the best of all them, is about 12 to 15 microns. The axial thing varies, and it can be around 4 to 5 microns. So if there is a fluid which is present, which is say 4 microns, you will not detect it.
Yes, yes.
So if you are not able to detect minimal fluid and the patient is symptomatic, I treat it.
Definitely, sir.
One injection, and I've seen responses, and I get puzzled why the patient responded. But then if you look at the pattern of the octa, you will see there is a maturation of vessels. The maturation of vessels can be identified, and that is important because we are not seeing any leakage, but the maturity of the vessels can be made out.
Definitely.
So next presentation is of Professor Dudani.
Thank you.
What I will say that suppose if we have a subclinical lesion, which is detectable only on investigation, we can keep it under observation. And if we see a sign of progression, that becomes an indication of treatment, even if the patient is not symptomatic. Your take. Yeah, because you have two photographs, you can compare, means you may not measure, but actually you can compare, and then you can get a fair idea that yes, this disease is progressing, and you become rightful in executing a treatment. That's what my take is on this.
But Abhijat, I've seen that on octa, the CNVM doesn't go away. Even after multiple injections, it matures, The vessels are becoming more and more mature, and the pattern is becoming less of those capillary beds are there, and the major thick vessels come out, So I feel that these maturation of vessels, what I feel is that we'll again come back to PDT, to regress these mature vessels if they're still.
So PDT works there.
Yeah.
But there's sole limitation of,
Visudyne. Yeah, Visudyne is not available, yeah.
But why do you need to regress the maturation?
No, because that's why this disease is lifelong, no? You're seeing your AMD patients.
Any tissue to exist needs blood supply.
Okay.
So if you have mature vessels, if you have mature vessels in an area, that tissue also, it's the leaking vessels which are problematic.
Okay,
it
yeah,
is
that's also a
not the
point.
mature
That's a
vessels. Otherwise, any mature, if I have a mature vessel, I kill it. No, I don't.
Right. That's also
Why
a
should
point.
I?
Yes.
Why should I be going after a mature vessel? There is no reason.
Exactly.
Yeah.
And so exactly, if in OCTA, if you're seeing progression of the plexus of the CNVM underneath, but patient has no symptoms, in that case, will you inject? No.
I think there's a very nice study which was published in Retina and probably also in American Academy of Ophthalmology, where they looked at the changing patterns of CNVM when it's a dry area. It's not dry empty, but actually it's dry, and then do you treat it or not? That's a question they asked, and they showed that yes, in certain cases, in certain situations, it makes a difference.
Yeah, if you have a one-eyed patient, the other eye is scarred, there could be some criteria, and the patient has slight metamorphopsia. I even treat an extrafoveal leakage, which is there in one eye, disciform scar. There's no subfoveal fluid, but there's an extrafoveal fluid which is visible. Then I treat that patient with anti-VEGF.
This same study that Sir is talking about.
Yeah.
They claimed at the end was that if it is rather a fresh CNV,
Okay.
it somewhat regresses with injections.
Okay.
Even if the patient is asymptomatic, but once it gets old, there's formation of a scar tissue there, then there's no use
Yeah,
of
irreversible
injecting.
loss. Yeah. Great.
Yeah, Professor Ajay is a famous retina surgeon from the western part of the country, and we will listen to him.
Thank you for your kind invite, Dr. Malay. So lasers I think have still a place, as we discussed before, in retinal vascular diseases and inflammation. And I think that Eales disease was brought out very beautiful by Professor Saxena. So basically, vision impairment in retinal vascular disease and inflammation is the leading cause in these patients. DR, RVO, uveitis-related macular edema. So I feel even in patients with pars planitis, I've seen that there is always some inflammation, which in these patients, the peripheral part, if there is a lot of vasculitis, I do treat with peripheral laser. Lasers are a gold standard, I feel, versus anti-VEGF. I'll tell you all why. So the pathophysiology, as I will just take an overview, diabetic retinopathy, there's hyperglycemia leading to microvascular damage. Similarly happens in retinal vein occlusions, where there's vein occlusion and retinal ischemia. Uveitis, there's a breakdown of the blood-retinal barrier in all these Eales cases and the uveitis cases, which is leading to inflammation in the retina. So the role of lasers in retinal diseases, PRP, as we saw in the previous presentation, reduces the ischemia and anti-VEGF release. And it's a finite treatment, unlike anti-VEGF injections, which is a continuous ongoing cost to the patient. Focal and grid laser, as was discussed again, is still used in all our patients because of the cost constraint of multiple injections in both DME and RVO edema also. And we also use laser retinopexy for retinal detachment in the periphery in patients with these fibrovascular polyps, which we see in Eales disease. I've seen sometimes the combined detachment, so you can use lasers for that also. So laser is a very strong cog in your armamentarium of treating retinal diseases, the vascular and inflammatory component. So VEGF basically promotes the abnormal vessel growth. Anti-VEGF inhibits the VEGF, and it has revolutionized the treatment and improved vision in most of our patients. But the downside is that the frequent injections are required, and the patient has to keep coming back, which is not very much possible in a third world country where the cost also is a constraint, and the patient coming back with their children is also difficult. So this is a brief, comparison between lasers versus anti-VEGF. So the mode of action, lasers work in destroying the ischemic peripheral retina. So you have, you don't have the hypoxic retina releasing more VEGF. So you have neutralized the constant VEGF source which is there. Anti-VEGF agents will just block the VEGF-related leakage. So I think, anti-VEGF drugs have a anti-exudative effect also and an anti-inflammatory effect, which we are very much aware of, because they stabilize the inner blood retinal barrier. So there is definitely a prevention of leakage in these patients, and that works as an anti-inflammatory effect. Lasers are best for proliferative diabetic retinopathy and RVOs with neovascularization, especially the BRVO with NVEs. Anti-VEGF forms the backbone in DME, CNVM, and CRVO edemas. So the point I want to lay stress is lasers has a permanent effect vis-a-vis the evanescent effect which is there in anti-VEGF effect injections which require repeat injections. The side effects, as we discussed in the previous discussion, that the peripheral laser might cause a visual field constriction. If you're doing a central macular laser, over 30 years now that I've got gray hair, I've seen that my scars, which I thought were way away from the fovea, they've actually come and eaten away my fovea, and I've had loss of vision, these patients. Patients are the vision has dropped from, you can say, 6.6, they have come down to 6.60 because of the foveal scar just impending the fovea, So I think we have to be very careful in, as was discussed by Dr. Ajay, that you stay away from more than, 700 microns at least away from the center of the fovea because of the scar enlargement. But the injections have the side effect. I've seen that I have had myself endophthalmitis even with, the innovator molecules which we have used, and nowadays we have patients developing vasculitis, vein occlusions, and also inflammatory uveitis with recurrent injections. Even when they've taken 10 injections, the 11 injection, the patient comes back with a hypopion, So that's a bugbear which we have, which we don't see in lasers. And the cost, laser is a one-time cost, it's a one-time investment for the patient and for you. But this is an ongoing treatment cost, I think, which, is not very possible for our poor class of patients. So what are the current guidelines and treatment protocols? In diabetic retinopathy, we use PRP for proliferative diabetic retinopathy. And in vein occlusions, PRP for ischemic retinal vein occlusion, not necessarily CRVO, because there's a controversy whether CRVO, you will do peripheral laser, because unless you have extreme non-perfusion, then only we do, as per the CVOS study. And if you have NVI, you do that. And in uveitic macular edema, steroids, anti-VEGF, and lasers can be used, especially in the patients who develop central yields, as Sir showed beautifully. So in those patients, definitely you do laser. And even as for central yields, I've done, central laser also, just focal laser to the areas of leakage. As I think Dr. Ajay will speak, his favorite topic of sub-threshold micropulse laser, which is a non-damaging yellow laser which is used in DME. But I'll just share with you my experience of using an 810 nanometer is what I had for last, 15 years. I've been using 810 diode laser, which is a very cheap laser. And I've been using it for various diabetic macular edemas. And because it's a very longer wavelength, it causes minimum damage, and it creates automatically a sub-threshold burn because you don't get that whitening, whatever power you may keep, So I have had experience of using diode from last 25 years, and it gives very good results, though the lesion, the laser reaction might not be seen. The other advances are the navigated laser therapy, which was discovered by our friend Dr. Chablani. Then the pattern scan laser has made our life very easy, where you're doing multiple spots at one time. But I still prefer to use indirect because it's cumbersome sitting on the slit lamp and doing it. And selective retinal laser therapy is the future thing, where they say that it'll specifically target only the RPE cells and stimulate it, Like you could say photobiomodulation is the new thing for dry AMD, which they're saying, which is a type of a light, laser light, which could be used, So this is just a few cases, like, cases of ischemic CRVO. So we gave 3 injections, and then these patients I also do a peripheral pan-retinal photocoagulation after the hemorrhages have cleared. An impending CRVO, a case of a IT BRVO. So this is another well-lasered BRVO. You can see that you can actually quieten the full disease, and you can prevent multiple injections for these patients because your peripheral retinal ischemia is leading to macular edema also in these patients. I have seen that, we feel that CRAO might not require any lasers or anything else, but I've seen that CRAO very commonly develop neovascularization and directly NV eyes and glaucoma. So in these patients also, we require, if they develop NV eye, we do a PRP in these patients. So this again, my protocol is you do 3 injections and then you always do a PRP in these patients. So this again is showing you a patient of PDR with macular edema. So you treat the macular edema with injections and the peripheral neovascularization with laser in these patients. So I think in my case, so I was speaking to one of my colleagues from Joslin Diabetes Institute, which is there in USA. So actually they have retired their laser. The laser room is nowadays actually defunct. So all patients are receiving only constant anti-VEGF injections, which is okay for a Western country like USA, but I think in our case, my laser is still very actively working in my clinic at least. And also I'm in a medical college where we are definitely treating these new vessels elsewhere, which you can see. Once you see them, we are starting a PRP, and I feel the tight PRP is the way to go. And Eales disease was discussed very well by Professor Saxena, so I won't go in. I think that is where the confluence of retinal inflammation and neovascularization there's no better example than that which I've come across. But I've also seen in patients with viral retinitis, where you get, frosted vein angiitis also. In those patients also, laser does have a strong role along with the treatment of the antivirals drugs, So the real world evidence is the protocol S, the DRCR ka, that, they compared the PRP versus anti-VEGF, and they showed that a combination worked better. The patients with, only anti-VEGFs developed lesser vitreous hemorrhage and lesser diabetic macular edema, but they required lifetime follow-up, which is not possible for our patients, The Bravo and the Cruz study also showed that these injections work very well. So I think retinal disease management, lasers are used for targeted therapy for specific retinal conditions, and anti-VEGF therapies inhibit vascular endothelial cell growth and reduce the abnormal blood vessel growth. But there are limitations of laser, retinal scarring, loss of peripheral vision, and is ineffective in patients with AMD and widespread macular edema like diffuse diabetic macular edema. And the anti-VEGF therapy challenges are that frequent injections, poor patient compliance, like, you have had many patients who take 3 injections for DME, then they're lost to follow-up. They come back with a recalcitrant, elevated thing. So they're saying, what have you done, doctor, So the disappointment is quite sad in these patients. And then if you combine it with laser, so my protocol is a patient with DME comes, you give him 1 injection, 2 injections, and then if you find focal leakages, you don't necessarily need to do an FFA, but like an Octa can guide you, Octa guided, or even at the center of the hard exudates, if you do a very mild laser, you don't have to hit the white reaction in these patients. You can definitely reduce the number of injections in this patient because you're stimulating the RPE cells was the theory which we got, which is helping to stabilize the blood retinal barrier. And endophthalmitis I have seen in patients with injections, so that is also a thing, and multiple injections lead to increase in IOPs and, as I said, vasculitis and various other inflammations. So what is the future I feel of retinal treatment is that AI protocols, you will optimize laser and injection schedules using for individualizing for the patient. Like, you will feed the data into this patient that the first year he required so many injections. So you know that in the future, that fellow will tell you, as per the AI protocol of multiple patients which they've collated, what will be the future of this patient, because this Grok and everything, ChatGPT is making our life so much more easier. So I think definitely there are going to be AI protocols which will come into the future. Injection regimen for each patient will be individualized, rather than having a general thing, Then gene therapy is the new thing. Rather than having multiple injections, there's a gene, the anti-VEGF gene, which has already come into the market and is in the phase 3 of trial. And you will have a future, I think, a robotic delivery where all said and done, when we are doing laser, our hands are shaking, we are not able to do this. So if a robot could help us, I'm sure that is soon going to come. Before we even blink our eyes, we'll be having a robotic delivery of laser, which will be more precise, more perfected with the exact, amount of lasers depending on the RP, pigmentation, whether you're a dark pigmented or light pigmented eyes. So I think all those protocols are what is coming in the future. So optimizing outcomes, I think lasers have a role. Anti-VEGF is definitely there. So I think we have a symbiotic relationship or a synergistic relationship between them two with a combination. So you can reduce the number of injections. So my last conclusion slide, I'll say lasers remain essential in managing ischemic retinal diseases. Anti-VEGF therapy has revolutionized treatment but has its limitations as we discussed. Combination therapy is the future. Personalizing treatment to patient needs is what AI will guide us and lead us to future. And emerging technologies, I think the way we are seeing the gene therapies and, subretinal injections or, suprachoroidal injections will optimize retinal disease management. So the future for retinal disease is very bright. So if I develop diabetes, I'm looking forward to, future extreme advanced treatments to maintain my sight. Thank you very much for indulging me. Thank you so much.
Yeah, the good part is that we are really running in time, and that is what retina surgeons are known for. And I asked Professor Dr. Ajay Arora sir to come and take up his presentation, but just one question till he picks up the mic. What will happen to peripheral CNP areas? Are you going to treat them with laser?
In diabetes?
In diabetic retina.
So I think there are two different ways to look at it. One is CRVO. CRVO, there's still a controversy whether you treat the peripheral CNP areas unless the patient develops neovascularization or no, because the macular edema is constant injections. So I feel two diseases which require lifetime anti-VEGF injections is AMD, wet AMD. If anybody says it's a finite disease, I beg to differ. And even CRVO comes close to that. Whereas diabetic macular edema, as we have seen that first, second, third, fourth year, the number of injections keep on reducing. So I am a very proactive guy in treating peripheral neovascularization. So all my patients with, you can say, pre-PDR disease also, I do peripheral scatter laser. But with the anti-VEGF coming in, the severity of the laser, like what I call as, creating an RP fundus has become less. So you can do a milder scatter laser in these patients and let your anti-VEGF also help synergistically, so your laser is not that dense or that bad. So I feel you don't necessarily need to do a retinitis pigmentosa fundus where you have a full scarred retina.
I agree with you, sir, because looking into the compliance of the patients that come to in our nation,
yes.
They will stop coming and then they'll blame you.
कि
डॉक्टर साहब आपने इंजेक्शन लगा दिया तो और खराब हो गया.
नहीं इंजेक्शन लगाया पैसा ले लिया, forget about that. और मेरी विजन तो उतनी की उतनी हुई. So just one case I want to ask Professor Saxena sir, I'm treating a young patient of 40, he's now 49 years of age, of Eales disease. He keeps developing, vitreous hemorrhage recurrent. I have done AKT for him. I've done total, you can say, extreme PRP for him. Every time he comes with a hemorrhage, I do an injection intravitreal and the hemorrhage clears. But still he's keeping on getting recurrent hemorrhages. What is the reason you feel, sir, he's developing that?
With chronic vasculitis, sometimes, and I've also published also that this kind of vasculitis is not seen clinically. It is so these kind of cases, they just go on, and there is a subclinical type of vasculitis which goes on. Okay. So you can keep him on a long-term azoran therapy for 3 months or 6 months, and then you can see.
Great.
Clinically, you will have a so-called normal kind
of
a fundus, but that subclinical inflammation keeps on going.
Thank you so much, sir. Thank you.
So now, Dr. Ajay Arora, and after that we'll discuss.
So at the outset, I must thank Malay for this, innovative and thoughtful IC he has put together. I wish it was held during the daytime, not at 8 o'clock in the morning, for more audience participation. Can I have my slides, please, sir?
I think one point I'd also like to add in both Eales disease and PDR would be the undoubted role of vitreous itself as a scaffold. So like these cases with the recurrent hemorrhages, I think in early vitrectomy, when you have these cases, as per your experience, in Eales disease, when he's developing proliferation with flat membranes and has a first episode of vitreous hemorrhage, maybe just before, prior to that, would that be a good time to, because that will improve the oxygenation as well as the VEGF load could come down?
My concept until now has been that if the hemorrhage is not resolving on the first go,
Treat with
in a
anti-inflammatory.
meaningful manner, I think we should go for a vitrectomy. But that chronic kind of hemorrhaging is perhaps due to
Inflammation.
ongoing inflammation.
That would also require a vitrectomy, you think, so that would also, that would not be an indication of vitrectomy.
So my talk is on DME therapy current status, and we will overlook these basic definitions because this slide was made based upon various definitions. And all of us must understand the differentiation between CSME versus the classification which is put together of a center involving diabetic macular edema and a non-center involving diabetic macular edema. And it is extremely important to understand that it is the central 1 millimeter area which is the center involving diabetic macular edema. It is not the entire macula which sometimes people consider, though we tend to give intravitreal injections to patients even beyond the central involving diabetic macular edema and not do lasers. The cascades I will not go through, but it is also important that patients who need a good metabolic control, like for this patient, this was many years back. He was one of those people who was very much into yoga and self-healing. He refused any treatment, and you see how the response was after 6 months. Dramatic reduction of the heart X-rays, dramatic reduction of macular edema with no anti-VEGF injections. So it's very important that all diabetics at all stages must be treated with a good metabolic control. This patient came to me in a multi-speciality hospital, first time. Patient, this is the sort of edema the patient had. We did not give any anti-VEGF injections. Patient was put on dialysis, and see 8 months later how beautifully the macular edema is dissolved. So what I'm saying is it's important to take care of the metabolic status, take care of the kidneys, because that's how it works well. This is a patient who had thalassemia major, and her macular edema was not reducing. This is again 2008. It just happened to be mother of a very important lawyer in Delhi, and later on he's become a good friend. So when he came to me, we were injecting Avastins, and then I said, okay, let me inject Lucentis because I wanted to top it up over what others had done. But it did not improve his hemoglobin. Her hemoglobin did not go beyond 9. And that stage, vitrectomy was not done for non-tractional diabetic macular edema. I went ahead and vitrectomized both the eyes when there was no definitive proof available for doing a non-tractional edema diabetic vitrectomy, and it has worked. She was happy for a long time. This is again just to show you what an laser means for an extra foveal laser and how beautifully these patients respond. I will not go through these anti-VEGFs. This is just to show you some of the slides that whenever the patient comes to you, the OCT may not be very clearly representative. Just go ahead and treat them, and how patients respond well after multiple injections. Initially, the anatomy also will be very difficult to understand, but it's very important to go ahead and treat them and manage them. Then all cases of tractional diabetic macular edema must undergo a surgical intervention. Don't keep on injecting these patients because it doesn't really work. So this is just some examples of this thing. This is to show you that there are factors other than VEGF, like the ICAM, IL-6, MCP1, pigment epithelial derived factor, which have a role, and there was a meta-analysis which showed the relevance of these factors. It's important to recognize the biomarkers of inflammation and diabetic macular edema, and these are some of the biomarkers like the hyperreflective dots, the hyperfluorescent diffuse DME, foveal hyperautofluorescence, and neurosensory detachment, and cystic spaces. So whenever I find patients who have cystic spaces, who have hyperfluorescent dots, my
treatment in these cases is more towards giving steroid. And this is an important table. I wish you could just remember this, that what are the biomarkers which correlate well with anti-VEGF, what are the biomarkers which correlate well with steroids. So whenever we give corticosteroids, the corticosteroids have both effect, an anti-inflammatory effect and also an anti-VEGF effect. And this has been shown in many of our cases whom we have treated with steroids, and they have responded extremely well. I'll now come to, can I run this video? I hope it runs on this. Okay, let me see. So this is just to show you how we inject suprachoroidal injections. This is a very simple device. It has now it has got almost patented. I've received the initial communication, and this will then soon be able to send it for somebody to manufacture it. And this, I have a very large series in these cases, and it has done well. So this was an example. Suddenly in India, in about 2-3 years back, we had a short supply of Ozurdex, and the patients with persistent diabetic macular edema, you can see how bad the macular edema looks. This is a patient who had a cup disc ratio of 0.7, was an anti-glaucoma treatment, and this was one of the initial cases of diabetic macular edema whom I had injected suprachoroidal injection, and you see this beautiful response after SKITA in these cases. There are multiple cases like this. There are defined Retina guidelines of using corticosteroids in these cases, but basically if you have a patient who has got a cardiac event in the past, corticosteroids should be used. If you have inflammatory biomarkers positive in a diabetic macular edema, you have to try to use corticosteroids, and it works pretty well. So there's now, as Ajay Dudani mentioned about the use of micropulse laser, I will not go into the physics behind it, but it's been shown that micropulse laser works well in diabetic macular edema by multiple studies. This was one of the initial studies of Vojovisk, which had shown that even the microperimetry was maintained in these cases which were treated with micropulse laser. This is an example of a patient who had an extrafoveal edema. We treated with micropulse laser, and the patient responded well. I have been doing now treating patients with proliferative diabetic retinopathy with DME, and I have more than 10 years follow-up in about 3 patients who are willing for undergoing micropulse laser. We had taken a special consent because these patients, I am doing a treatment other than PRP. So this is follow-up of one of those patients whom he comes to me once a year. So you can see the Octa images over last 5 years, how the superficial capillary plexus, the deep capillary plexus has changed in these cases, and and these patients I have not given, we have not done a PRP for him. So this is his pattern of after a wide field angiography. You can see the areas of capillary non-perfusion. So these are the areas which I have done only micropulse laser. Whenever we detect an NV, that is treated in a localized manner, rest of the areas is maintained. What is the advantage of all this? We have been able to maintain the fields. So I have monitored the fields since last 4 years. The field has not deteriorated. The patient comes to me once a year. Once a year I give a micropulse laser in these cases. I don't have to inject into them anymore. So micropulse laser with a combination of continuous wave laser is doing well. Like persistent DME patients sometimes can have, you should do a wide field angiogram. Like in this particular patient, you will have large area of capillary non-perfusion. You can see those leakages. You laser those areas, and once you laser those areas, gradually the edema comes down. You again do not have to keep injecting them. Try to find out the offending cause, and it really works very well. So these are the various biomarkers which correlate with visual acuity. I will. There is. I think paucity of time and not talk too much about drill, but it is extremely important. And it's extremely important for all the cataracts, all those who are doing cataract surgery, that you must treat diabetic macular edema before you take up the patient for cataract surgery. This is what happened to a patient who was not treated well. 2 weeks post cataract surgery, this is the situation they landed up into, and this can become medico-legally important. This is an algorithm which we made, which was published, and this is how a DME is to be treated. And the key takeaways from this talk is good metabolic control. Anti-VEGFs are the first line of therapy. Steroids have a significant role. Intravitreal corticosteroids act by the anti-VEGF property and block inflammatory mediators. Suprachoroidal steroid injections are showing very good results and can be made to work for a longer duration of time. Now what we are doing is we are centrifuging our triamcinolone, and our centrifuge triamcinolone, what I'm using, works for 7 months. There is not one product in the market that works for 7 months. That means I give 2 injections a year and it's working extremely well. Thank you very much.
Yeah, fantastic. And his suprachoroidal thing has really revolutionized. And there was a question from this lady sitting next to Partha Vishwas. Yeah, you please come.
Oh, we are so glad that Dr. Patho is here. Maybe it's the next welcome, President, sir.
And till she is asking question, Dr. Partha, we had a very good session. This is discussing a new thing, inflammation and neovascularization in retinal diseases. And it was a very interactive session, like Professor Ajay Dudani was there, Sandeep Saxena told about EASE disease, and we had a very nice presentation. The only thing people are saying that a better slot would be useful in the times to come.
Maybe now Patho is here, we'll get a
yeah, that's what I took the opportunity, because a very yeah, a quick comment and then we will wind up.
Sure. Hi, this is Dr. Kiran Turaka. I'm from UPMC Harrisburg. Congratulations, Dr. Ajay. Great talk. Great talk. So you know that when we are doing, you're talking about controlling the systemic disease is important before even we kind of shoot an injection or shoot a laser or do the things. So same, I'll ask you, like for your patients, when you said that you kind of have to give these injections repeatedly, but still like there is a kind of subclinical kind of vasculitis there. So my question to you is, how about treating the systemic thing? Is the patient having any kind of active tuberculosis or a secondary tuberculosis? Has it been addressed in the past in those patients who are getting like kind of recurrent vasculitis? Were they treated in the past, or do they have anything kind of active infection now?
So my patient was treated for tuberculosis about 10 years back. When he was a child, he had received a full treatment with AKT.
Sure.
So I, repeated his Mantoux. He was about 10 millimeters. So I told him, let's do a repeat course of, AKT based on that, because you're getting recurrent. But he was very, refusing to take a repeat course of treatment. So he took a chest physician's opinion, and he also was saying that there's no need for AKT. And he was refusing. So most patients don't want to go again for that 9-month-long therapy, these
Right.
EELS patients. So.
Yeah.
So I was stuck up in this patient.
Right. Yeah, but you don't have to give every time 9 months treatment, and Mantoux is not going to help much, because being
True.
Indians, we all have
Yeah.
we get BCG vaccine, so we already will have
True,
a positive
true.
Mantoux. Like getting a quantiferon gold.
Yeah, that
or-
was negative.
That was also negative.
HRCT
Okay.
chest was negative. So
Right,
then
right.
the chest physician was very reluctant. So I think what Sir said, maybe I could, give him, I'm giving him steroids, but I think switching him to Azoran with steroids might help, is what I was thinking.
Right. But whenever we are kind of giving the steroids, there is kind of a
Reactivation.
flare-up of the infection.
True,
so
true. Yeah,
then
it's
you
a-
got to be kind of extra
Very true.
cautious while giving the steroids
I
for
agree.
any patient with the past history of tuberculosis. Even if they were treated like 20 years ago,
Right.
they kind of get the flare-ups.
Very true. I agree with you on that.
All right. Okay,
Thank you.
you.
Thank you, ma'am.
So with that, I think we conclude the session and hand over the mic to the next series, and we'll have a photograph. Yeah.
Thank you.
Just as you're getting ready for the photograph, one small announcement. I think it's a big announcement for me. That is coordinating with Dr. Manish Shanmugam and Dr. Kim for a diabetic retinopathy pan-India program, and AIOS with VRSI will do it. And this would be a part of my presidential project. So thank you very much, Kim sir and Mahesh. And Dr. Manisha is not here, but she's been in touch, and we'll roll out. And today at the lecture, I'll definitely mention this. Thanks to VRSI for all the help.